Hey, podcast listeners, Fawaz Al-Mufti here from Westchester Medical Center at New York Medical College, and this is the Neurocritical Care Society podcast. Traumatic brain injury is a leading cause of death and disability. Hypothermia has been hyped as a treatment to reduce secondary injury following TBI, as there is scientific rationale and experimental evidence that neuronal damage at the cellular and molecular level is highly temperature sensitive and that hypothermia is neuroprotective. Several studies have been conducted with mixed results. A meta-analysis of the highest quality clinical trials of hypothermia and severe TBI was conducted by the Brain Trauma Foundation, which reported a significant increase in long-term favorable neurologic outcomes. The Eurotherm trial demonstrated a greater risk of death and worse neurologic outcomes in survivors managed with therapeutic hypothermia compared to standard therapy. Some would argue that long-term outcome in TBI is multifactorial, so would it be realistic to expect that any one intervention can change that? If my back's against the rope, should I induce hypothermia with a goal of reducing ICP in patients with severe traumatic brain injury and saving my patient? Or should I target normothermia? Is it the fire or the ice? Today, Chris Zammit will discuss with Dr. Nichols, one of the authors of the POLAR trial, their findings that were published in JAMA late last year. I hope you enjoyed this episode.
Good morning, and thank you for listening to this edition of the Neurocritical Care Podcast. I am Chris Zammit, Assistant Professor of Emergency Medicine, Neurology, and Neurosurgery at the University of Rochester. Today we are delighted to have Dr. Alistair Nichol from Monash University in Melbourne, Australia, with us to discuss the results of their recently published trial entitled Effect of Early Sustained Prophylactic Hypothermia on Neurologic Outcomes Among Patients with Severe Traumatic Brain Injury, or better known as the POLAR Randomized Clinical Trial, which was published in the December 2018 issue of JAMA. Dr. Nichol, thank you so much for taking the time to discuss your work with us today.
It's my absolute pleasure to be here. Thank you very much for the invitation.
Absolutely. So if you don't mind, for the listeners, can you tell us a bit more about yourself, your interests, and your origins?
Yeah, sure. So my name's Alistair. I'm a critical care clinician. I also have a particular research interest. And one of those research interests, obviously, is trauma and looking after patients following severe traumatic brain injury, which started this whole piece of research. I have the pleasure of working in Melbourne, Australia, in Monash University in the Alfred Hospital. But I'm originally Irish, and I worked in Dublin. And I have a really neat work arrangement where actually I spend a good bit of my time concentrating on clinical trials and work between Dublin and Melbourne.
That's amazing. So let's dig into the POLAR trial. So can you start off by giving us some background on the previous work that was done on hypothermia and traumatic brain injury, and based upon that prior work, what the POLAR trial sought to ask about the role of hypothermia in traumatic brain injury?
Yeah, sure. So I have to bring you back to 2007 when this all started. George W. Bush was the president at that time, so this is a while ago when we started to put together the POLAR trial. And at that time, the Brain Trauma Foundation, who put forth international guidelines on the management of the severely injured patients with traumatic brain injury, produced those guidelines, and it, for the first time, recommended, now albeit with a low-grade recommendation, the clinical use of prophylactic hypothermia. So if you looked at that meta-analysis, there were a number of smaller studies which showed beneficial effect, and one larger study which had shown no effect. But at that time, there were a number of methodological concerns about that study, which suggested that really, if we wanted to know the true answer and the true effect size of prophylactic hypothermia, a new study that addressed these shortcomings needed to be conducted. And that was in the environment or the atmosphere in which we conducted the POLAR study. So
in the design of the POLAR study, how specifically did you seek to explore that question?
These trials are big efforts. They take a long time, and you probably have only so many of them in your academic lifespan. So we worked hard as a group to try and get this right. So we sought to see what were the previous concerns or flaws of the other studies, and how could we address it in advance. And in particular, we had the help of Jamie Cooper and Steve Bernard, who had particular interest in traumatic brain injury, but also in hypothermia. And there were a few key things that the meta-analysis had shown. Ideally, the patient should be as cold as quickly as possible after the injury. So that actually would mean inducing hypothermia at the roadside or as quickly as possible in the emergency department after the injury. As you can imagine, cooling a patient who's just suffered trauma is not without potential risks. As we know, hypothermia can contribute to bleeding. So we designed a protocol where we would cool people to 35 degrees at the roadside. And we thought that was the perfect balance between hypothermia to protect the brain and the risk of hypothermia contributing to bleeding. And then once the patient reached the emergency department, we'll scan from head to toe and then was able to exclude major bleeding. They could be cooled down to 33 degrees Celsius. A few other key factors were the previous trials hadn't induced hypothermia for very long, generally 48 hours, and we felt that was inadequate. The brain blossoms after a traumatic brain injury, and 48 hours is generally a time when the risk of elevated ICP is probably at its highest. And if you think about it, those trials that turned off hypothermia on a time-based trigger, in severe septic shock, we don't turn off noradrenaline after 48 hours. We titrate it to physiology. So what we also did in this trial was everyone got cooled for at least 72 hours in the protocol. But if they still had elevated intracranial pressures at 72 hours, we kept them cold for longer. And we only rewarmed them when their ICPs were normal, and also that they weren't rising when we rewarmed the patients. And then finally, we rewarmed them very slowly.
And what method of hypothermia induction did you all use?
We used two methods. So you can imagine when the paramedics arrive at the roadside and there's cars upside down, the police and the fire service are there, they have limited resources with them. So what they carried with them was a drinks cold container with 2 liters of ice cold saline. And they induced hypothermia with the administration of 1 to 2 liters of this 4 degrees Celsius normal saline. And once the patient randomized to the polar group arrived in the emergency department, they had automatic surface cool blankets attached to them from their trunk and limbs. And that was set to 35 degrees and then subsequently to 33 degrees.
And once the temperature target was reached, were there any standardized methodologies of monitoring for and controlling shivering?
So the answer was yes. There was a protocol that looked at that, but the management of the shivering was largely left to the bedside clinician's discretion. All of these patients would have been intubated, so they would have been received induction dose of an anesthetic agent and paralyzed at the scene, and that generally would have been through the initial phases of the hospital as they went to scan, etc., and then up to the ICU.
Now, do you all have any data on any differences in the burden of shivering between the different groups? I didn't notice anything in the primary manuscript, but perhaps it was in the supplemental materials.
No. So what previous authors have found is shivering doesn't tend to happen at 33 degrees Celsius. It tends to happen on the way to it. So once the patients arrived in hospital, we didn't notice an increased burden of shivering, but we didn't specifically collect it in our case report form.
Did you guys have any type of methodology or structure for how you would maintain common standard treatments for traumatic brain injury across your sites? I understand it was performed, if I recall correctly, on 3 continents, Australia, some Asian sites, as well as Europe.
Yes, so these would have been major trauma centres that would have had and pre-hospital ambulance services as well, which would have had a track record of big clinical service as well as clinical research experience. And they would have all agreed to sign up to the common guidelines, which at that time were the 2007 Brain Trauma Foundation guidelines, and then the next iteration when they came out. For the polar patients, we had a small run-in phase where, without randomization, a patient was included at the site and they were able to see were they able to deliver the different aspects of the intervention. And that was done at the first few sites before just to make sure we needed to finesse the protocol or give any other information to bedside clinicians so they could deliver it safely and consistently.
Great. Was there any kind of guidance given to the sites on general triggers for or necessary information for when withdrawal care considerations could come into play for these patients?
That's a really interesting question. So the short answer was no, right? We left those considerations to the bedside clinicians looking after the patients. However, these were young patients enrolled into our study, and they would have been given aggressive care. So prognostication would have happened down the line, and patients who would have died earlier would have died because generally they were unsupportable.
I know those can be difficult conversations. I think, as we all know, the TTM trial gave some rough definition for when those thresholds can be considered. But as you mentioned, traumatic brain injury can be pretty complicated. Speaking to your inclusion-exclusion criteria, I know that you all excluded some patients who appeared already perhaps at risk for death by hemorrhage with a heart rate of greater than 120, low systolic blood pressure pre-hospital. Any other notable inclusion or exclusion criteria for this study?
We had inclusion-exclusion criteria pre-hospital and then in the emergency department. And the pre-hospital were essentially, it had to be something simple that the paramedics could operationalize. And essentially it was people who were too sick and maybe had already coned, people who were likely to be bleeding to death, and people who may have been intoxicated as the cause for being unconscious at roadside. In the emergency department, we were able to supplement that information with fast scans and CT scans.
What was the time frame from injury to induction that had to be achieved in order to be a part of the study?
Again, our goal was hypothermia as early as possible. So they had to be within 3 hours of the trauma. Obviously, none of our patients were able to provide consent themselves. We had got a deferred consent model approved, which allows patients who are incapacitated because of their illness to be enrolled in a study. And in this context, if there were next of kin available in the hospital, we would have asked them for consent, but that was rarely the case in these sort of injuries. There were very few withdrawals from patients next of kin due to withdrawal of consent. As a part of this, we took some public engagement on board, and we had done some informing of the community that this trial was underway so that members of the community would have been aware that the study was going on in their city and there was a chance that they may be enrolled in it.
In the States, we're about to embark on the BOOST trial, looking at cerebral oximetry in traumatic brain injury patients. And, one of the elements here is that once, if we are at the point of then monitoring for cerebral oximetry and then peeling back and just somebody withdraws consent and saying, we were monitoring it and looking at it and fixing it, and then somebody withdraws consent, does that mean we blind ourselves or whatnot? So what I'm curious in with that background, if one of the patients who was randomized to hypothermia then had consent withdrawn, what was the process then in managing their temperature going forward? Was it to rewarm them? If so, how fast? Or was it to continue them at the hypothermia and to use different triggers? What kind of guidance was given in that situation?
It's a really good question. So the answer was, it depends. And it depends on the views of the patient's next of kin. So different people have different reasons for not providing consent to participate in a trial. For some patients and their relatives, it was that they didn't want to take part in the 6-month outcome assessments. And if that was the case, we always would have asked patients, can we use their data up to that point? Some patients would have said we don't want our data to be used at all, but they didn't mind whether the intervention was continued as per protocol or not. And then if somebody asked that their relative would not contribute to any of the data and they didn't want the hypothermia continued, the patient at the discretion of the treating bedside clinician, so it would have been off protocol, could have rewarmed the patient slowly.
Great. Thanks for those insights. I know it's a challenging situation, and certainly I know a lot of folks who are listening to this would be interested in how you handle that just for future trial planning. So getting to your outcomes, what was the primary outcome and what kind of effect size were you guys looking for? And if you don't mind sharing some of the secondary outcomes as well.
So our primary outcome measure was the GOSE. So that's the Glasgow Outcome Scale Extended. We also had a number of secondary outcome measures, and they were principally mortality. We were also worried about infection and the risk of bleeding with the use of hypothermia as well. And we had some pre-planned analysis. And these were a per protocol analysis and an intention to treat analysis. Because we wondered if all the patients in the hypothermia group would get an adequate dose of hypothermia. And we hypothesized that the patients who got more hypothermia may do better. So, 10 years after starting the trial, after randomizing 511 patients into both groups, there was no difference at all in GOSE at 6 months following injury in patients who got hypothermia compared to normothermia.
Any findings on any of those secondary outcomes or those planned subgroup analyses?
So the pre-planned secondary outcomes, again, showed no difference. There was no difference in mortality. So that made the subgroup analysis all the more important to see, look, was there a difference, but for whatever reason our overall protocol didn't detect it. It was only in the patients who got loads of hypothermia that we found this. So was there still a hint of an effect in the per protocol analysis or the as treated analysis? And the answer was no. The only significant effect we found was in the patients who got a high dose of hypothermia defined by our per protocol and as treated analysis, that they had an increased rate of infection, which again was one of our pre-specified hypotheses because previous studies have suggested that hypothermia may be associated with increased rates of infection.
Any comments on the temperature execution, the achieving of the goals, maintenance of goals, any variance in the temperatures from the protocol?
We achieved hypothermia in the hypothermia group quite quickly, but there's a caveat there. We got them to 35 degrees Celsius. However, when we went back and actually looked at the overall results, the patients who got to 33 degrees Celsius, it took nearly 10 hours to get them to 33 degrees Celsius. And those findings are not much different than Guy Clifton's NAVISH study. So what that said to us is we can cool people to 35 in a modern trauma system, but we have real difficulty getting them to 33. And that delay is because when they arrive in hospital, the neurosurgeons want to look at things, we need to scan them, the intensivists want to look at things, they're worried about bleeding. It took us longer. So by looking at our per protocol analysis, the results were not different from the patients who got an adequate dose of hypothermia. And we also did another analysis which looked at, were the outcomes different for the people who reached hypothermia quickly versus the people who did not? And the answer was no.
Did the publication of Eurotherm have any impact on Neurol's ability to recruit and enroll patients in the study?
So when Eurotherm came out, as you know, so Eurotherm suggested that late rescue hypothermia may be detrimental in patients following severe traumatic brain injury. So a number of things happened. So I suppose the first thing is we had always felt that prophylactic hypothermia, so that's hypothermia induced really early, is different from late rescue hypothermia. So our whole hypothesis was the hypothermia at the get-go will mean that the brain doesn't swell, you don't get as much of the ICP elevations, and that when you're delivering hypothermia late as a rescue therapy, that we had felt the horse had sort of bolted to that stage. So we had a different construct for how hypothermia works in those two situations. The second thing is, though, we talked widely to our community, to our trial site PIs, Data Safety Management Committee, and what we did at that stage is they went back and looked at the data that had accrued to date, and they told us to continue the study, but with a slight modification that they would then look at the outcomes of patients after every subsequent 50 additional patients had been enrolled, an additional safety measure to make sure that no patients in our study would be subjected to harm.
Very good. That's very interesting. Thanks for sharing that. Any other comments on the results or findings from the study?
So there would be two things I'd say. One is, while we were pretty disappointed that it didn't show that hypothermia was beneficial, and if you had asked me back in 2007, I would have bet that hypothermia was going to be good. But that turned out not to be the case. And because it was a clean kill as well, I think the clinicians can be pretty confident that this intervention, which requires a lot of education training, will not improve outcomes in patients following severe TBI. But a take-home message here is not that temperature does not matter. Our control group was not whatever you fancy yourself. The control group was actually tight normothermic control. So we had wondered about some of the previous studies that had not had tight normothermic control in the control groups. That the classic way is your trial is positive because the control group gets suboptimal or not great care. So we tightly controlled the temperature in the control group, and that meant actually that they got the surface cooling pads if needed to maintain their temperature normal. So we stringently avoided pyrexia in that group. So the take-home message would be, while prophylactic hypothermia does not work, strict normothermia is the standard of care.
That's great. And any future planned research based upon these results or in this area, or any pre-planned analyses that we can look forward to?
So Polar has addressed the question of prophylactic hypothermia following severe traumatic brain injury. Eurotherm has addressed the question of late rescue hypothermia in severe traumatic brain injury. So there are a few areas of hypothermia in TBI that remain unanswered by those two trials. And they would be, is hypothermia beneficial in late refractory elevations of ICP uncontrolled by other first or second tier therapies? And the answer is, we don't know. It's probably unlikely that any trial is going to address those questions. So I think they are going to remain gray areas at the moment. There are a number of subgroup analysis from Polar that we're going to look at. But we think we've pretty much addressed that main hypothermic question. We'd like to look into the infections a little bit more as well to see if there's other predisposing factors that may have contributed to infections in the patients who got it and how that might have affected their outcomes. I think the final thing would be to thank the patients and their relatives who contributed to the study. I think it's added a considerable bit of new knowledge. And while, unfortunately, hypothermia has not proven to be beneficial, strict controlled normothermia should be the standard of care in these patients.
Well, thank you for, again, spending the time today to answer questions and to describe the results of the Polar trial with us. Again, congratulations to you, all your co-investigators. And of course, as you said, we certainly are eternally grateful to both you all, the patients, and the many other folks who contributed to the execution of the protocol. So thank you very much. Appreciate it.
You're very welcome. And on behalf of myself, Jamie Cooper, and all the other investigators, it's been our pleasure to take part in this today. Thank you.
The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. Our production staff includes Romani Ballou, Mike Brogan, Josh Levine, Sarah Stern-Nezer, Benjamin Miller, Storeen Shepard, and Chris Zammit. Our senior producer is Jim Siegler. Our administrative staff include Angel Gindel, Sarah Mimmin, and Becca Stickney. Music by Lee Rosever under a Creative Commons license. The Neurocritical Care podcast series is available on NCS On Demand and wherever you may listen to your podcasts. For more information, please follow us on Twitter at Neurocritical or Facebook. I'm Fawaz Al-Mufti, and thanks for listening.